Good day everyone, this is Dr. Farah. Today I will briefly talk about ankylosing spondylitis, which is a chronic progressive inflammatory arthropathy, and it predominantly involves the axial spine and the sacroiliac joints. And the common scenario that you will encounter is a young patient who is like in 20s or 30s, and most of the times the patient is under 40. Initially comes with symptoms of dull pain, and the trend of onset is insidious, and the regions that involve the pain are the lower lumbar area or the gluteal region. Initially it can be unilateral, but with progressive progression of time the pain can develop bilaterally. And if it's bilateral, it usually involves the hip joints, and clinically the patient presents with bilateral hip arthritis. Now, how will you diagnose and confirm based on clinical criteria? So, to qualify as the criterion for ankylosing spondylitis, the patient has to have a chronic pain at least more than 3 months. The pain has to be in lumbosacral or the hips. The age of the patient has to be less than 40. The onset has to be insidious, and the pain usually improves with exercise, and the pain never improves with rest. And actually the pain exacerbates when the patient is asleep at night, and the pain at night can worsen so much that it usually wakes up the patient from deep sleep. So that's how severe the pain can get. So the pain does not improve with rest. In fact, it exacerbates with rest. So nocturnal pain is very common criterion for ankylosing spondylitis patients. And now the pain can be because of muscle spasms, and the pain can be definitely it's a bone involvement. On a palpation of the bone, the pain exacerbates. So the pain is both muscular and it's secondary to bony involvement. Now, how will you diagnose a patient with ankylosing spondylitis? Firstly, there's a strong risk factor. In most of the cases, HLA-B27 is positive, but this is a common but non-specific lab finding. Similarly, ESR and CRP are often raised but not always. So CRP and ESR are not definitive. There is mild anemia, and there is an elevation of the serum IgA levels. Serum IgA levels are elevated in ankylosing spondylitis, and but yes, the disease activity can correlate with a marker known as matrix metalloproteinase 3 levels. So serum matrix metalloproteinase 3 levels do correlate with the disease activity in ankylosing spondylitis. Arthrocentesis is not beneficial because the findings are non-specific inflammatory. And if you do a pulmonary function test, then you will see that the vital capacity is decreased and the functional residual capacity is increased. But at the same time, the airflow is normal and ventilatory function is well maintained. So basically, the serum marker that is important in ankylosing spondylitis is serum metalloproteinase 3, which correlates with the disease activity. Now, what are the radiographic findings? Radiographically, you will notice sacroiliitis, which is usually symmetrical, and on X-ray, you will see the blurring of the cortical margins of the subchondral bones, which is followed by, in late stages, erosions and sclerosis. So this progression of the erosions, it usually leads to pseudo-widening of the joint space. As fibrous and then bony ankylosis supervene and the joints become obliterated in the later stages. So this is very important to remember. And in the lumbar spine, because of the progression of disease, you will see a straightening of the lumbar spine, and the lordosis, which is the usual pattern, it's lost, and reactive sclerosis is prominent. Reactive sclerosis is caused by osteitis of the anterior corners of the vertebral bodies with subsequent erosions, and this is where the squaring and barreling occur. So these are the common findings. The active sacroiliitis is best visualized by dynamic MRI with fat saturation, and the common test that is done is the STIR, sort of MRI, short toe inversion recovery, STR. And it can also be ruled out by the other MRI type, which is T1 weighted images with contrast enhancement. But this can be a potential exam question, that how will you rule out an active sacroiliitis, which test will you do? So you will go for an MRI with fat saturation, either T2 weighted turbo spine echo sequence or the STIR sequence. So basically you have to remember MRI with fat saturation. Now on X-rays, you can see the bone mineral density loss, the dual energy X-rays, absorptiometry shows loss of the decline in the bone mineral density, which is also non-specific, and the location where you check the bone mineral density is the femoral neck and the lumbar spine, and it's more prominent at the L3 vertebral bodies. Now, how will you treat a patient? Basically, the initial treatment is NSAIDs. Now, what is the benefit of NSAIDs? Well, definitely it does reduce pain, and secondly, the NSAIDs do slow the radiographic progression. This can be an exam question. NSAIDs reduce the radiographic progression. Now, if NSAIDs do not work, then definitely you have to start TNF-alpha monoclonal antibody inhibitors. And what is the role of these TNF-alpha monoclonal antibody inhibitors? Actually, the patients do show progressive improvement in both the clinical and lab measures of the disease activity. So there is clinical improvement, clinical functionality of the patient improves, and so does the lab markers. So the indices that are checked on clinical examination are the spinal mobility, and at the same time you have to rule out the patient's pain level. You have to check for the peripheral joint swellings, and you have to rule out morning stiffness. So basically what's checked: morning stiffness, pain, both muscular pain and bony pain, the spinal mobility, and the peripheral joint swelling. And in the lab markers, I just told you, the metalloproteinase 3 is done, and you can also go for CRP-ESR, but it's not all the time raised. So again, what is the benefit of TNF-alpha inhibitors? It reduces the BASDAI score, BASDAI score. This can be an exam question. And how much does it reduce it? The TNF-alpha inhibitors reduce the BASDAI score by 50% at least. So now if the BASDAI score is more than 4 and the patient has active disease and the patient's pain is unbearable, then NSAIDs won't work. This is inadequately responsive for the NSAIDs to work. So definitely you have to start the TNF-alpha inhibitors. Well, the usual protocol is that you have to at least you have to begin with NSAIDs. And if that does not work, then you go for anti-TNF therapy. So I hope it's clear that TNF therapy, anti-TNF therapy, it improves the BASDAI score. So before that, yes, you do have to go for the PPD skin test to rule out tuberculosis. This is very important. There are many contraindications to the TNF alpha inhibitors, like you cannot give it in infections or pre-malignancy or malignancy or other certain autoimmune disorders like SLE and also multiple sclerosis and pregnancy. Cannot give it. So then you have other options, like you can give according to the patient's history. You can consider other drugs like methotrexate, although it has not been methotrexate has not been shown to be beneficial in ankylosing spondylitis, but there is still research going on. So there are other new drugs that have been introduced, like ustekinumab and secukinumab. Ustekinumab, ustekinumab, which is anti-interleukin 12 and 23 inhibitor, and secukinumab, which is secukinumab, which is anti-interleukin 17 monoclonal antibody inhibitor. So these are very efficacious in clinical trials, but they have not been approved. So now, if the patient has a severe hip joint arthritis, what's the next step? It is definitely surgery. And what type of surgery? A total hip arthroplasty. So this was the brief summarization on ankylosing spondylitis. If you have any further questions, you can contact me at clients@3mdiagnostics.org. Thank you. Goodbye.